Bismillahirrahmanirrahim. Assalamu alaikum. This is Dr. Masood Umar. I'm an associate professor at the Aga Khan University Hospital and currently heading the orthopedic section there. In the next uh, 15 minutes or so, I'll be taking you through the technique of how to do a hip reconstruction osteotomy with an Ilizarov frame. So we will not be discussing the indications or the theories about the technique, but I will be demonstrating you on a sawbone model where to insert screws and how to angle your screws so as to achieve the best clinical and radiological outcomes. So for that, I'll just start with sharing my screen and move on. The first slide would show the orientation of the shank screws in the proximal femur. They are heading toward from the greater trochanter towards the calcar area. And if you see the long axis of the bone, and the angle they make dictates the valgus angle of the proximal segment. So we have marked in red as the level of proximal osteotomy. And then we start distally, we start inserting shank screws, which are inserted at an oblique angle after the transverse wire from both medial and lateral sides. We attach the distal ring in the special shank screw attachment device on a single two-hole female. And this is how the distal ring is attached. Then another ring is attached proximal to the distal ring. The distal ring can be a full ring or even a 5/8 ring if that permission is allowed, dictated by the level of fixation. And then we fix the distal ring, that is shank screw fixation. We usually cut the shank screw to achieve a wider purchase of the bigger diameter of the shank screws. That's shank screw insertion again. And this is how I fix the middle assembly, which is the middle ring. Sometimes it is a 5/8 ring or a big arch, depending on the diameter of the thigh. If you see, the red lines dictate the axis on the horizontal axis of the bone. The angle these two red lines are creating dictates the varus angle that the distal fragment would ultimately go in. So I deliberately fix the middle ring at a certain angle, which it subtends with the distal assembly, so that once we make a osteotomy in the middle and connect the two rings, they would subtend a desirable varus angle. Further attachment of the assembly. Now, the attachment of the arch to the proximal segment is also critical, and if you now notice the angle the arch makes with the long axis of the femur in the lateral view or in the sagittal plane, it is the arch is tilted downwards, as you can see, and also has a tilt in the valgus direction, which was dictated by the orientation of the screws. As soon as we make the proximal osteotomy and bring the arch to neutral, the desirable correction in the sagittal plane of the proximal fragment is created, which dictates about an angle of 20 to 30 degrees of hyperextension at the subtrochanteric level, and also in the coronal plane. By now the desirable valgus angle has also been achieved. Again, another view to show you the valgus angle that has been achieved. This is the AP view and this was the lateral view. Now we make the distal osteotomy, the giggly saw, and that's once we connect the ring, the middle assembly to the distal assembly, we would create the desirable varus angulation at the distal site and a neutral knee joint axis. Now this is an AP final view showing you the proximal valgus angulation. The proximal fragment is making the distal osteotomy making a varus angulation with the proximal fragment, and the knee joint line axis is now horizontal. So this is a three-dimensional procedure, osteotomy. So insertion of the screws dictates, and the attachment of arch proximally dictates the creation of a valgus and hyperextension angle. The connection of the proximal and middle and the distal assembly dictates the varus angle that is desirable. Ultimately, you can achieve a very successful radiological and, of course, a clinical outcome. I thank you for your attention. Assalamu alaikum.